Bismillah ar-Rahman ar-Rahim. Assalamu alaikum, everybody. It's our pleasure to welcome you all to our first Pediatric Neurology Club in the Western region. Also, we are happy to welcome our guest attendee through the virtual platform. I would like to take the chance to thank the Saudi Pediatric Neurology Society to give us this chance to organize such a club. We hope that we get this club going over the next year, almost monthly, to discuss challenging cases about pediatric neurology cases in the Western region. Without further ado, I would like to welcome our speaker today. She is a pediatric neurologist and pediatric epileptologist. She is a lecturer and associate professor at King Abdulaziz University. Without further ado, please welcome Dr. Halima Al-Youbi.
Thank you for inviting me, and I would like also to thank the Saudi Pediatric Neurology Society, and thank you, Dr. Muhammad, for this introduction. So we will start our case presentation. I choose this case because the end of this patient is actually a mortality case, and unfortunately we lose this patient. I would like to learn from what happened to this case and discuss the case more. So we'll start now. She is a 20-month-old baby girl and presented to the emergency at our hospital with non-provoked convulsion, generalized tonic-clonic in one side, and tonic convulsion in the left side. These convulsions associated with uprolling of the eye, drooling of saliva, and mouth deviation, and actually the patient continued to convulse, we initially, as you all know, in the emergency, we started the ABC, secure airway, and make sure the patient breathing well, and secure the IV access to her. We take blood gas and other blood work. The patient started with midazolam load twice, and the seizure still ongoing. So, of course, we go through the second line treatment of status epilepticus, and the patient received phenytoin, Keppra, and phenobarb, and still seizing in the ER. The ICU bed was arranged for her, and the ICU team take over the patient with midazolam infusion. The patient intubated, of course. So this is a definition of status epilepticus. Status epilepticus is any epileptic seizure lasts more than 5 minutes or 2 or more seizure with incomplete recovery in between the attacks. What about the refractory status epilepticus definition? It's the status epilepticus that fails to respond to adequately used first line and second line therapy. And of course, in this stage, patient usually require anesthesia. Based on the 3-class randomized control trial of appropriate first-line drug treatment, result in seizure termination in about 65% of patients with midazolam, based on the evidence-based medicine, and based on the American Epilepsy Society guideline, published in 2016, the recommendation also in the initial treatment is also benzodiazepine. What about the second line therapy? 2 open label trials consider the concept study in Australia and New Zealand, and the Eclipse study from the United Kingdom also recommend benzodiazepine. They have compared levothyroxine and phenytoin in children with benzodiazepine refractory status epilepticus, and they found clinical cessation of seizure activity 5 minutes after infusion were not statistically different between the 2 groups. Overall, around 50% to 70% of participants achieved primary efficacy endpoint. And the trial in US established status epilepticus treatment trial, also comparing levotiracetam, fosphenytoin, and vigadepakin, and they led to seizure cessation and improved alertness by 60 minutes in approximately half of the patient. The three drugs were associated with similar incidence of adverse effects and also similar efficacy. So given the lack of class 1 trials, decision about second-line treatment are often based on local availability, cost, and most importantly, the specific patient factor. This is a paper showing there is no evidence-based preference in the second-line choice, either IV fosphenytoin, IV valproic acid, or IV levotiracetam. They have similar efficacy and side effects. Okay, going back to our patient. When we go back to the patient, of course, the patient referred to neurology, pediatric neurology, and we went to check up the patient in the BICU, open further history taking. The patient had history of recurrent upper respiratory tract infection symptoms and fever for 4 months prior to presentation. She had multiple clinic visits, received multiple courses of antibiotic for this fever episode, and diagnosed as otitis media. Then 20 days later, she admitted in Egypt with decreased level of consciousness, admitted to ICU in Egypt for 15 days, and diagnosed as autoimmune encephalitis. Received corticosteroid therapy, IV, IG, and antibiotic. Investigation there were all normal, including MRI, CT and EEG. Also, a metabolic screen was done. The patient improved, then discharged home. After discharge by a few days, she has opened the history. The mother claimed that the patient improved, and level of consciousness also improved gradually. But the patient still having delay of development, and she had myoclonic convulsion in the right limbs, and continued to use levotiracetam maintenance dose. She was also followed with neurology clinic there, and she was given, as I said, Kebra. 1 week prior to presentation to our hospital, she developed 2 episodes of convulsion, tonic-clonic convulsion in the right side and left side tonic movement, persistent and associated with uprolling of the eyes, rolling of saliva and mouth division, and lasted for 15 to 20 minutes or 30 minutes. Then went to private hospital, levotiracetam dose was increased, and then discharged home. This is what happened 1 week prior to presentation. At the day of presentation, or sorry, 1 day before presentation, the convulsion episode increased in the right side, and then the patient, but the conscious level was maintained. She is medically free, otherwise no previous admission other than the one we mentioned, no surgical admission. Antenatal is also unremarkable. Immunization is up to age. Developmentally, she is having developmental delay. Family history, there is consanguinity, and there is 3 normal siblings, no abortion. There was a family history of mortality in her aunt. She died from adult onset epileptic encephalopathy, but actually we don't know what kind of encephalopathy, and no workup were done for her. The patient in the ER, based on the examination, vitally stable, other than the convulsion, no rash, no fever, no neurocutaneous stigmata, no dysmorphic feature, and CNS examination also was, of course, when we see the patient, she was encephalopathic on midazolam infusion, so the Glasgow scale was low, but otherwise she has hyperreflexia, but maintained the gag reflex, pupil was reactive, there was hypotonia, truncal hypotonia all over. So the goal of therapy for this patient to control seizure, first of all, and preventing initial excitotoxic injury to the brain, avoid, anticipate, and treat multi-system dysfunction resulting from ongoing seizure activity, patient receive medication, and establishing the cause and the risk factor for her. So what is the differential diagnosis for this case? With prolonged status epilepticus, we think maybe autoimmune encephalitis, neurometabolic disease like mitochondrial disease, and neurogenetic plus the infectious cause. What happened to the patient? Patient still on midazolam infusion, and we follow the status epilepticus protocol in our center. The patient also covered with antibiotic to cover for encephalitis. We started methylprednisolone therapy, assuming it could be autoimmune encephalitis, and we asked for imaging for the brain. And the patient also referred to metabolic team, ID, and genetic. And this is the initial laboratory. The patient have some increase in white blood cell and increase in lactate. And this is the initial CT scan for her. There was no acute infarction, no injury to the brain, nothing. And we did, of course, the CSF study, and it was unremarkable. And we sent for antibody from the CSF and from the serum, NAMDA, and we sent also for virus screen. So we treat this patient as refractory status epilepticus. So she was on midazolam, as I said, we reached 4, and there was no clinical convulsion after that. But the patient spiked temperature, the pupil was echoreactive, positive gag reflex. As I said, the patient received methylprednisolone, she is on phenytoin and Keppra as a maintenance. Then the patient improved the next day, and the midazolam was weaned. But unfortunately, at the night, she developed tachycardia and unequal pupil. So we resume midazolam, and we load her with Keppra. This is her MRI study with MRS and MRV. And this is the impression. There was left posterior parietal cortical restriction, and it could be post-seizure activity based on the clinical context. However, the acute infarction is one of the differential, and we cannot rule it out. Also, there was focal diffusion restriction of the left hippocampus, and it could be also due to the repeated seizure. There was also diffuse decreased deep white matter volume, which could be perinatal insult. The vascular signal void and enhancement was maintained. The patient sent also for referral to cardiology, and there was normal result of echo. And this is her EEG, first EEG. As you see here, there is continuous seizure from the left hemisphere, and the other hemisphere, the right side, is also abnormal with delta waves, delta brush, and slow waves. So also in the EEG there is periodic lateralized epileptic discharges, which come also with the status epilepticus sometimes. So we consider this status epilepticus partialis continua. And we suggest this could be infectious or inflammatory caused. Our impression could be autoimmune encephalitis, like Rasmussen's encephalitis, or could be herpes simplex encephalitis. So the ID team also want to rule out herpes simplex encephalitis. But all the CSF samples sent for herpes simplex was negative. The patient stopped vancomycin, but continued acyclovir for 3 weeks and ceftriaxone based on the ID recommendation. I put this figure to show the differential diagnosis here as a neurology, and we think this could be anti-NMDA encephalitis based on the presentation, the relapse in here, and the status epilepticus partialis. The patient initially in Egypt improved with steroid, so that what make us think about this. So what is the Rasmussen encephalitis? As you know, it's a rare progressive chronic encephalitis affecting one hemisphere. It occurs mainly in 6 to 7 years old children. The symptoms, as you know, seizure, hemiparesis, cognitive impairment, and the causes is immune disorder. We did MRI. In these cases, the MRI is conclusive, and it usually presents with the progressive atrophy of one side of the brain, but it could be later on. So initially, MRI can be normal. The disease is usually expressed to burn itself out, but not before the patient is left with significant hemiparesis, visual field loss, learning difficulty, and usually ongoing epilepsy. The syndrome can spontaneously stabilize at any time. Very rarely, in rapidly progressive cases, can lead to death. And the treatment, as you know, the steroid and IVIG, and we can also start rituximab, for example, as chronic therapy. The cure for the seizure, for this syndrome is, as you know, the hemispherectomy. Back to our case, the patient on midazolam now, 6 mic, increased midazolam based on the protocol, still seizing. She has on exam on and off tachycardia, and then unequal pupil. The patient, medication-wise, she's using phenytoin, levetiracetam, phenobarb, and methylprednisolone. And we aggressively treat her EEG. We want to suppress the seizure in the EEG, so she's hooked to the 24-hour EEG. Midazolam was increased. So we go now to define this case as super refractory status epilepticus. Why? Because this persists for 24 hours or more after initiation of third-line therapy. So based on the evidence-based guideline, there is no clear evidence to guide therapy in this phase. Chronic choice include repeat second-line therapy or anesthetic doses of either thiopental, midazolam, pentobarbital, or propofol. In the lab result, we sent for metabolic workup. Ammonia, lactic acid, blood gas were normal. Almost everything reassuring here. And the impression of the metabolic team, it could be infantile onset of epileptic encephalopathy with significant family history, highly suggestive of inheritant caused, either metabolic or genetic cause. And they're planned to start vitamin B12 and send for ophthalmology exam and the whole exome sequence. The ophthalmology exam was normal. So what happened to the patient in the ICU again? We start ketamine infusion. We add ketamine on the midazolam because the patient is still seizing. There was no fever. As we said, the metabolic team increased pyridoxine and vitamin B12 in the medication list. The patient still having seizure, sometimes myoclonic convulsion in the right hand, on and off face twitching, and EEG hooked for 48 hours. And this is the EEG. So, as you see here, sorry, it's not very clear. There is still continuous status epilepticus in one side of the hemisphere. So we consider this epilepsy continua, partialis continua. And we think maybe this patient have sort of severe encephalopathy, like fires or NORS. What is NORS? NORS is new onset of refractory status epilepticus without a clear acute or active structural toxic metabolic cause in a patient without epilepsy or other pre-existing relevant neurological disorder. So it's a clinical presentation and not specific diagnosis. Fires is part of NORS with prior febrile infection between 2 weeks and 24 hours prior to the onset of refractory status epilepticus, with or without fever at the actual onset of seizure. So yeah, the patient fit the fires definition. So after the ketamine, the patient still seizing, so we add thiopental, and we add, again, after the thiopental, also we add propofol because of the continuous seizure. The metabolic team add thiamine, biotin, and folinic acid, but the folinic acid unfortunately was not available in our center. We arranged for plasma electrophoresis. She received 5 sessions, but no improvement actually in general. So on 27 July, after 48 hours, the thiopental weaned off, and propofol we reached very high dose, 1 milligram. The patient unfortunately have no clinical seizure, but electrographic seizure all the time. But there was no clinical seizure. Okay. And this is her repeated MRI. Because of the electrographic seizure, we asked for another MRI. And it showed the left frontoparietal hypodense area with loss of gray-white matter differentiation and effacement of sulci representing cytotoxic edema concerning of acute insult or could be related to post-ictal changes. Okay. So the patient, as I said, on propofol, it was 1, we make it 3, so we increase it. And the midazolam was also increased. The patient still having also some clinical seizure, like myoclonic seizure. The patient have unequal pupil and on and off tachycardia. After the propofol 5, the patient, because the patient is still seizing, we add valproic acid in her maintenance drug. We give loading and maintenance of valproic acid. Okay. And this is, I chose this study comparing the thiopental and midazolam and propofol infusion in the status epilepticus. We can see the control of seizure is somehow comparable between thiopental and propofol, but the problem here, the therapy failure because of the side effect is more in the propofol, more than thiopental. This study showing the ketamine for management of neonatal and pediatric refractory status epilepticus. This study provides class 4 evidence on the therapeutic utility of ketamine for treatment of refractory status epilepticus in children and adults, and it showed good efficacy. So as you know, the ketamine, we sometimes give it more in autoimmune encephalitis cases. So what happened back to our case? The patient loaded with valproic acid, phenytoin, phenobarb. The patient still having electrographic seizure, but no clinical seizure. This is the result of NMDA study, and it is negative. The patients start to be hypotensive, and of course, as the ICU team, we think because of a lot of infusion, so we started to take out the thiopental or reduce it. And the patient also stopped the plasmapheresis because of this hypotension and started epinephrine. We kept visiting this patient almost every day, and we think maybe the ketogenic diet here have a role, or maybe a surgical intervention. This is international consensus recommendation for management of new onset refractory status epilepticus, NORS, and fires. This is very busy slide. I don't bother you about it, but it mentioned there is a role of ketogenic diet in the initial therapy of these NORS and fires cases. Unfortunately, we didn't give the patient ketogenic diet. It's that time it was not available in our center. So this is the option we have until now. A word about ketogenic diet. In the 1920s, pediatrician at Johns Hopkins University postulated that the anti-epileptic effect of starvation resulted from ketosis, and it's possible to maintain a state of ketosis by the diet. And the mechanism of action here, ketone bodies has direct stabilizing effect on the central nervous system. Changes in fluid and electrolyte balance result in reduced seizure, and changes in lipid concentration induced by the ketogenic diet has also anti-seizure effect. So what class is a class 4? And this is about the vagal nerve stimulation. What is the mechanism to reduce seizure? Can alter the synchronization of epileptic discharges and increase the refractory period of neuronal discharges, or alter membrane or neurotransmitter function. Of course, it's considered as a last result. It's a class 4. Okay, what about the surgical resection? When we refer to surgery in this case, a decision for resection depends on if neuroimaging identify a potentially epileptogenic lesion with neurophysiologic evidence for seizure onset from that lesion, and the location, size, and nature of such lesion and functional significance of the surrounding context. The decision making is more complicated if the brain MRI does not show the lesion, like in our case. So we are not sure if the surgery here will help the patient. So in case of MRI negative epilepsy, additional tests required, either non-invasive functional mapping or functional MRI. Also, we can ask for PET scan, SPECT, MEG. We ask actually for functional MRI study, and this is the resting state. And this is the report of the MRI study. So the MRI, we were not able to, it's not really conclusive. It only showed the hemisphere atrophy. One hemisphere. So we did family meeting, and actually, as always, the family refused the surgery. So of course, no surgical intervention can we do for this patient. Unfortunately, the patient on maximum dose of antiepileptic medication, maximum ketamine, the patient finally have fixed dilated pupil, no gag, no cough, no tachycardia, nothing. A trial of diazepam was given, A loading of phenobarb was given, no pupil response. So it's not seizure, it's almost final stage. The EEG was requested and done, showing encephalopathy, no epileptic seizure. We asked for emergency CT scan, showing re-demonstration of the left frontoparietal diffuse loss of gray-white matter differentiation with mild effacement of corticosulci, no midline shift or hemorrhage. And some of the lab results here. All infusion was weaned, and we discussed with the patient this is a poor prognosis case. Patient did not improve to medical treatment of status epilepticus, and we discussed quality of life. Family meeting was daily updated and done regarding the plan, the prognosis, and high fatality rate of this patient. After 2 days, the death was announced. This is a study showing the outcome of therapy in refractory status epilepticus and super refractory status epilepticus, and what is the recommendation. It's as you said here, as you see here, it's 35% of mortality. So we kept with these two questions: what is the most likely underlying disease, and is any role of biological agent for this case? We have the WES result released, and it was negative. But it was showing a variant of unknown significance of gene BNP for further workup. The PNP is purine nucleoside phosphorylase deficiency, and it caused here immunodeficiency due to purine nucleoside phosphorylase deficiency. And the patient actually fit immunodeficiency because she presented with recurrent fever and infection. So recurrent infection, neurologic signs, low serum uric acid level, and lymphopenia in childhood could be the cause of, could be a purine nucleoside phosphorylase deficiency, as in our case. So this is her uric acid level, lymphocyte level. Her uric acid is 30. We did it twice. So in our case, the patient presented with history of recurrent upper respiratory tract infection, symptom of fever, no positive culture, no signs of infection. She presented with, of course, developmental delay and recurrent convulsion. She also has lymphopenia. So metabolic and genetic team was convinced it could be a B and B. Finally, to take home message, this is the last slide. A multidisciplinary team approach, as you see here, is a key for reaching the diagnosis and treating the patient. Always identify your role, your goal, and reevaluate it according to the clinical situation. PNP deficiency should always be considered in patients with recurrent infection, neurologic signs, and low uric serum uric and lymphopenia. Negative molecular test is not excluded for genetic disease. Thank you very much. If we have any question, I'm happy to answer the question. Yes. Yes, the mic is coming, Doctor.
Thank you very much, sir. I know this is one of the difficult cases one can face in the clinical practice, and I'm sure you must have had sleepless nights until we reached a conclusion. The history is so fluctuating and so rapidly deteriorating that obviously the differential diagnosis which you considered was absolutely accurate to the direction. The only thing which comes to mind was because nowadays they are doing autoimmune antibody panels. So other than NMDA, there are other GAG and other antibodies which could be responsible. And sometimes it happens that, as you concluded, some neurometabolic disorders or immune deficiency, sometimes they unmask the underlying autoimmunity and lead to a conclusive diagnosis where the two diagnoses are likely. We had a similar case where an unmasked urea cycle defect come up in a child of about 6-7 years, and it turned out to be GAG antibody positive also, status epilepticus. That child with us recovered and lived for some time, but ultimately succumbed to the recurrent infection and other complications. So this comes to the mind that there could be two disorders, one unmasking the other, leading on to a sort of poor prognostic value. So this is very good presentation, mashallah.
Yes, thank you, Doctor. I agree, yes, about your suggestion. And actually, we sent for autoimmune panel. All was actually, I'm not sure about the result of all. I only received the NMDA one. The other one I didn't receive yet. But yeah, as you said, it could be one of the autoimmune encephalitis plus the B and B causing immunodeficiency, and one masking the other. Yeah, good thought. Excellent. Any other question from the audience or the virtual audience? Maybe the other question.
Assalamu alaikum. Thank you, Dr. Reem, for enriching lecture. My question in such cases, do you think that starting immune modulator medication early on is better than following the usual status epilepticus guideline, especially that the EEG from the beginning was extremely malignant?
Which one? Start what?
Start steroid and
steroid, yeah.
Such medication from the beginning.
Yeah.
Do you think it's better than following the regular guideline for status epilepticus?
Yeah, absolutely right. I think starting methylprednisone pulse and be very aggressive from the start. Actually, as you know, also methylprednisone is also having some role in status epilepticus per se, without autoimmune encephalitis. So in here, since the patient referred to us, we right away start methylprednisone. We are still thinking could be autoimmune encephalitis, the bad one. Yeah, Rasmussen, for example.
You didn't rule out Rasmussen though, right?
No.
Yeah, you didn't do brain biopsy.
No.
If
Very
was,
critical.
If it
Yeah.
was Rasmussen's encephalitis, then the guidelines all favoring hemispherectomy rather than immunomodulators treatment.
Yes.
All the studies goes with hemispherectomy for curing the disease, especially that this patient had epilepsia partialis continua, hemiatrophy,
Yes.
as you mentioned. So, and you did not rule it out. So I think it could be the one with your child.
Yes.
And this is so
excellent.
unfortunate
Yeah.
that the family did not agree to do the surgery.
Yeah, and the patient was very critically ill, and even neurosurgical team was not convinced to do any surgery in this point. Yeah, I agree. Some of the Rasmussen encephalitis, they show the hemiatrophy later on, but unfortunately in our
Correct.
case, it is really critical, and from the start, the patient quickly go to the atrophy. I have like
Because it's such a progressive disease.
It is very progressive very quickly in our case. But I have 3 or 4 patients with Rasmussen encephalitis, and they live, and we did the hemispherectomy, and they are very good. No seizure, and they
So
have
do I.
good.
I still remember that one patient. treated under the supervision of our beloved Dr. Saad Al-Yamani, and I learned a lot about Rasmussen with that case. She's now in school. Although cognitive skills were declining before surgery, but she gained a lot of skills after hemispherectomy. Even the hemiparesis improved a lot, and she's now a better version of herself. I still remember the child. I would like to thank you a lot, Dr. Reem, for such an interesting and beautiful presentation, and looking forward to more presentations to come in this club, inshallah. Thank you, Dr. Banji and Dr. Mudaffar as well, for the very beautiful organization. يعطيكم العافية.
Thank you very
صفيناز
much.
الحارثي.
Thanks. Thank you, Dr. Safinaz. Very nice talk. And regarding the Rasmussen encephalitis, yes, some of them, they have poor prognosis, like in our very bad case and unlucky patient. But some, they have good, as you said, at least the quality of life is improved over time, and the seizures stop over time. This is what the aim of the hemispherectomy is, just for the seizure mainly. Thank you very much. Any other question, or I might conclude my case. Thank you very much.